Oke, 3, 2, 1. Good morning or afternoon, everyone. We are from Bismillah team, and today we'll present our analysis on patient journeys, focusing on one key question. What factors influence whether patients return to the hospital after discharge? Instead of looking at the hospital encounters as separate events, we analyze them as a journey over time. When patients return, which diagnoses carry high risk and how geographic access to care and patient feasibility may affect readmission. Our main insight is that the highest risk patients are not always the most visible. Some are easy to identify because they return often, but others may be hidden due to access barriers, weak follow-up, or under-screening. Through this analysis, we aim to show how hospitals can move from simply reacting to readmissions toward identifying high-risk patients' journey earlier and preventing avoidable returns. Next.
Next to the second slide. So this slide answers two key questions. When do patients readmit and which diagnoses carry the highest risk? On the left, we see the timing of readmissions. Most patients return very early after discharge. The median is 8 days and the majority happens within the first 7 days. So the takeaway is clear. The first week is the critical window for the intervention. On the right, we see the highest risk diagnoses. They are dominated by severe infection such as MRSA, endocarditis, and prosthesis-related infection. Nearly 1 in 2 MRSA patients are readmitted, showing that readmission is strongly driven by high-risk infection. Combining both insights, patients with severe infections are returning quickly, often within the first week. So the issue is not just the diagnosis, but also what happens immediately after discharge. We propose two actions. One is follow-ups on the day 3 and day 7. And second one is automatic high-risk flagging for infection cases. In short, readmissions happens early and it's driven by specific high-risk condition. With timely intervention, we can prevent a significant portion of cases. Next.
We use happy ASA data from HRSA to measure doctor storage and combine it with our dataset. We found that patients in severe storage area are much more likely to be remitted, up to 42 times higher. Mild and moderate storage do not show much effect. Shawnee County has the most patients, while Geary County has the highest admission rate. Based on this, we suggest using telemedicine for follow-up care and increasing the number of doctors in this area. Next.
In this project, we aim to understand how social determinant of health influence patient risk and healthcare journeys. Instead of focusing only on diagnosis, we analyze factors such as stress, financial condition, housing, transportation, and lifestyle, as this often explains why patients become high risk. We start by cleaning the patient level social determinant data, removing incomplete records and focusing on relevant features. Then we converted qualitative answers into a numerical risk score. Example, no to low risk, sometimes medium risk, yes, or enable to high risk. This allows you to quantify social condition into a risk score, which we aggregate into a patient level risk index. We also carefully handle missing values since they can indicate lack of screening or patient engagement. Next, we engineer feature to represent the patient journey such as number of encounter, number of disease, number of social response, and missing rate. Finally, we apply K-means clustering to segment patients based on both the risk level and healthcare journey complexity, resulting in 5 distinct patient clusters. To interpret the result, I create a patient risk journey map, where the x-axis represents journey complexity, the y-axis represents average social risk, and the bubble size represents patient volume. This visualization allows us to see how patients differ not just by risk, but also by how they interact with the healthcare system. From the visualization, several important insights emerge. First, risk is not aligned with healthcare usage. Some patients with the highest risk actually have very low engagement, meaning they are invisible to the system. Second, we identified 3 types of risk: medical complexity, psychological risk, and most importantly, high risk patients who have the higher risk but minimal interaction. Third, this shows that social determinants play a major role in patient outcome beyond clinical diagnosis alone. In conclusion, this analysis highlights that healthcare systems should not rely only on utilization data but must integrate social determinant and better screening strategies. Because the most critical patients are often not the most visible, but the one we failed to detect. Thank you for your attention. Thank you.